Thanks, Rinki. And actually, Andrea Teng will be doing most of the talk, who's sitting over there, who's a public health medicine doctor with us. Look, there's just been too much conversation for me to resist. There's a few things I want to tie together as themes here. The first thing I want to start with what Robert said. Where's Robert? I saw him walking somewhere. Robert Vigahol. Right, there he is. We already know what to do. This actually caused a huge amount of discussion in our challenge as we started out. Because we do know a lot of what to do. But there's other researchers doing that stuff as well, and the challenge can't do everything. So we looked hard at what to do. Some of our research might be down there a little bit at the sort of the micro level, but remember there's a whole body of other research out there. Platforms like today are really important for saying things like, we know a lot what to do, where's the political will? But as a research program, we can't directly change that political will, but we can influence it. We did think a lot about the kaupapa of this challenge, and we carefully framed it as the right treatment for the right patient and the right prevention for the right population. A lot of population level interventions can be the same for everybody, getting the sugar out of the food chain, but we do live in a country with quite a lot of ethnic diversity, and there will be differences in prevention programs by population group. We already know what we need to do. That's largely about the risk factors here, social determinants here, treatment over there. There's a lot we know how to do here. That's the type of modelling that my program, one of my programs does, and things like tobacco, salt, sugar, you've heard about. There's a lot more to go on that. It's not to forget the upstream social determinants up here, doing stuff about child poverty, education, all that stuff, the long-term stuff that Nina was talking about. When we've solved this by 2040, I'll come back to 2040, probably more of the disease burden that's modifiable in the future will be due to treatment as we purge out those risk factors unless we discover some big new risk factor. But given the risk factor age we've been in for about 60 or 80 years of research, we've probably identified a lot of these in here, and it's about doing something about them. Nina, Andrew, Andy, and Richard Edwards from the floor all talked eloquently about targets. I want to put another one out there. If you look at the long-range life expectancy trends in New Zealand, I'll do it your way. Māori here, about 1880. European here, about 1880. They do this over the long run. They bump around. European go flat in the 60s and 70s because of the peak of the cardiovascular disease epidemic, and Māori catch up nicely. Then Māori go flat in the 80s with the delayed CVD epidemic, but also Rogernomics. And then they get up to here. Now Māori are starting to close in, about 1 or 2 years life expectancy gap closure in the last 10 years. But watch my fingers again. Now, 2040. If you draw those lines out using 1880 as your starting point, 2040 is when they cross, which is not a bad goal to adhere to, being 200 years after the Treaty of Waitangi. It also ties in with other international dates around 2040. That's my rant. What I'm supposed to be talking about is this thing called big data and the virtual health information network. I'm just going to briefly introduce it before I hand on to Andrea. So I'm going to give you an overview. We're going to use earthquakes as an example. I'm moving a lot today. Earthquakes, big event, kind of a small issue on the research front, but we're using it to demonstrate what you can do in this data environment, and that's largely what Andrea is going to speak to. We've got a really good history of using linked data in New Zealand. That's biased because I was one of the guys who started it with linking census and mortality data. But we now have these things called the virtual diabetes register and the health tracker, etc. And there's been a change in the way that we approach this. We are moving from Rod Jackson goes into the Ministry of Health, he grabs a whole lot of data, he takes it over here, he links it up to lab data, and he creates PREDICT, or VIEW as he now calls it. That's sort of bespoke record linkage. Now the idea is to leave all the data over there, and lots of people come into that data environment and ask questions of it. You now invest in the infrastructure and then ask your research questions of it. It's not just us, these places here. SHIP stands for the Scottish Health Information Program, FAR, ISIS, unfortunate that it sounds like ISIS, but it's spelled slightly different, in Ontario, which is actually a very good model. Hang on, 200 people in that organisation, compared to, say, 20 analysts we might round up in New Zealand. So we've got to be smart in how we do this. I think, who hasn't heard of the IDI? Actually, do it the other way, audience participation. Who has heard of the IDI? There's not many hands not going. It's pretty cool. It's pretty cool. This is now Scandinavia. We need to respect it and not do stupid bugger stuff like try and re-identify people. We need to respect this. We have the go forward at the moment. It's also having influence. I've just been in South Australia, Those guys are getting all their data together now, and what's the thing they often say we're trying to follow? This thing. Now, it's pretty cool, even if you just do this. If you just have the health data there, all our linked up health data in one place that's constantly refreshed, it's now a place you can go to and do your analysis in there, rather than pulling it onto your corridor and it getting 1, 2, 3, 4, 5 years out of date. You now have a playpen that's been refreshed you can play in. That's pretty cool. But it's way cooler than that because it's now linked to all that stuff. So you can now respectfully jump in there, see if somebody's been diagnosed with a coronary heart disease event, and see what happens to their income in the next month, year, 5 years, and do things like work out productivity costs. Very important. We've heard about morbidity today. Increasingly, we need to look at the not just health impact of our interventions, but what it does for other societal things that matter. Productivity of the workforce, so we can lift the retirement age, because it's going to have to lift somehow. Another rant. Okay, but the pitfalls. Let's get all the information you can. We'll think of a use for it later. You cannot get away from the critical importance of careful thinking about the research question. The data isn't going to magically give you the answer. Letting a machine learning algorithm run rip on it might give you good prediction, but it won't tell you about causal associations. Let's solve the problem by using big data none of us have the slightest idea what to do with. There is a bit of this buzz factor around at the moment. Our job as researchers is to make sure we demonstrate that we're doing good things with it that are useful. That's where I hope the Virtual Health Information Network comes in. There's a long story here. I'm going to do the brief one about the vision. It's to create and sustain an environment that captures value from linking health data collections through world-leading health research, policy development and service planning. You've got to have your big statement. Let's just drill down a little bit. Graham Osborne and I, who set up the Virtual Health Information Network, we said, well, what's the best thing we can do? We've got Scandinavian data. We're not sort of publishing that often in New England Journal of Medicine, and we could be doing more to help policymakers. Is it another machine that goes bing, or a really, really, really big machine that goes bing, bang, bang, bang? No, it was actually about the capacity of the human resource. And the vision that we've got is that when June Atkinson, I saw her up there, when she jumps in there and she leaves behind the costs on the health events, somebody else who comes along next and does a case control study on pancreatic cancer, they can get the costs to give a bit more context to their study. We leave stuff behind for the next people so that we can build on it and collectively create that productivity increase in our research output and our delivery for health service planning. So what we're going to do, what's happening at the moment, the VHIN's got some other lives, but within the healthier lives, it's got these 4 projects. We're looking at the Canterbury earthquakes as a demonstration project. That's what Andrew will speak to. Also, really cool, using PHO data, which has got the HbA1c, that's the biomarker for diabetes, and taking that data set and now putting that also in the IDI to try and work out which risk factors cause people to go from pre-diabetes to diabetes. Now, we may not quite have the numbers with this particular pilot, but if we can pull it off, there's nothing to stop doing it more widely. I think it's quite exciting. Boring question, but gosh, people want to know it, the prevalence of cancer. How many people alive in New Zealand at the moment who've had a diagnosis of cancer in the last 5 years or any time in their lifetime? We get asked it all the time by reporters. Once you've identified that population, you can then follow them to see whether they get second cancers or diabetes or whatever. And I've already talked to you about productivity costs. So the VHIN provides those things on the left, a massive sandpit of data that we need to respect. I'm going to use that word quite a bit. The National Science Challenge is chipping in, helping with, driving the VHIN as a test of that environment, creation of code and metadata that we leave behind for the next group, great understanding of the data strengths and weaknesses. There's nothing like getting down into data to understand all its weaknesses. There'll be lots of measurement error in there. Our job is to work out ways to deal with that and feed back to the data providers to improve the quality coming in the next few years. And a focus on collaboration and dissemination. And at that point, I'll hand over to Andrea.